fortunate in that today what we're doing is bringing together research happening in different areas of the UK, and I have colleagues here from Bradford and from London, and we'll just quickly introduce ourselves, I think, before I provide a quick overview of the seminar. We'll start with you, Pip.
Hi everyone, thank you very much for having us. So I'm Dr. Pip Shaw and I'm a research fellow based in London at University College London. And I'm one of the researchers who's been working on a project looking at the implementation of an innovation called UCLP Primrose.
Perfect, thank you. Gregor.
Hi everyone, I'm Gregor Russell. So I'm a consultant psychiatrist and R&D director for my trust, which is the Bradford District Care Trust in Bradford. And I've been leading the implementation of Primrose at the Bradford site, which I'll be talking about in a bit.
Brilliant, thanks, Gregor. And jumping up to the northeast, Ilaria.
Hi everyone, nice to meet you all. I'm Dr. Ilaria Pina, and I've been working with Emily Oliver on the whole SMI project, who is an adapted version to see the implementation of the UCLP Primrose in the Northeast.
And last but not least, Dan.
Hello, my name's Dan. I'm the research assistant also on the whole SMI project, and I work really closely with Ilaria and Emily as well up at Newcastle University.
Perfect, thanks team. So over the course of the seminar today, what we wanted to do was come together and share different learning from different sites, different approaches, but all trying to tackle a key issue, which is how can we really help people to live well and to thrive when living with severe mental ill health. I'll just share a quick overview slide to take you through the start of the seminar. So as I mentioned before, we're different research groups funded through different strands, but all trying to tackle the same challenge. Fundamentally, we know that people living with severe mental ill health face some of the starkest health inequalities, with much cited data around between 15 and 20 life years lost relative to the general population. And this has been an area of increased national attention and regional action. Primrose itself, as I'm sure Pip may speak to, was a large evidence-based programme to try and generate and develop a programme to support the physical health of people living with severe mental illness. And increasingly we've seen people living with SMI, the focus of attention in strategies like 420+5, really pushing the need for action to try and target these inequalities. We know that a lot of our physical and mental health services are going through large-scale transformation programs, but yet in practice, we still see that these areas are often siloed. And sorry, I think someone might have their mic still on. So these areas of practice are often siloed, and people living with SMI and their families and carers tell us it's often a challenge to have conversations about physical health and to think about thriving when management of their mental health condition is often foregrounded. We also know that different areas are progressing at different rates. So whilst in our work, which the researchers will talk about in a bit, we found some really positive examples of strong implementation and practice. In many areas, people found they had limited access to support, and it was sometimes a very challenging journey to try and connect with services and support professionals. What we have heard consistently is a need for a much more holistic way of thinking about health promotion that encompasses both the physical and the mental health component. And there's strong buy-in for this agenda from both health and care professionals we spoke to and from communities. The challenge really is, if we know where we want to get to, how do we get there? And that's what we wanted to share with you today. The learning from 3 different areas, trying different approaches to drive forward change in this population. So I'm excited to hear researchers share a sort of what's and all summary of some of the learning. What we'll do is we'll spend about 10 minutes talking about some of the key findings from each of the areas, and then there is a brief period where I have a couple of questions that I think it would be helpful for all the researchers to speak to, so we can pull out some of the differences in their experiences, and then we'll open up the floor to questions, comments, and discussion from the wider group. Equally, please don't wait until the final bit. If you've got a comment or a question, please drop it in the chat. I will be keeping an eye on it throughout so that we can make sure we have time to bring all those questions to the presenters. So without further ado, I'll hand over to Pip to start us off.
Amazing. Thank you, Emily. I'll just share my screen and check that you can see it okay. Can you see it fine? Got
Perfect.
a thumbs up from Dan. Thank you, Emily. Amazing. So for my section, what I'm going to do is I'm actually going to start with an introduction to what we've been implementing, which is UCLP Primrose. Then what I'm going to do is very briefly summarise our approach to our research and some of the overview findings. After this, I'll pass to Gregor, who will go a little bit more in depth and detail about the realities and barriers and enablers to implementation of UCLP Primrose on the ground. So to kick us off with what UCLP Primrose is. So Primrose was developed to address the health inequalities faced by patients with severe mental illness. So for example, diagnoses of schizophrenia or bipolar, who are at risk of cardiovascular disease. And by cardiovascular disease, I'm meaning a general term for conditions affecting the heart or blood vessels. So Primrose was developed with a lived experience advisory panel as well as, and it was designed to be a nurse-led structured support service delivered in GP practices, focusing on evidence-based behaviour change sessions to reduce cardiovascular disease risk. Now, there's a really strong body of research behind Primrose, both in its development and its effectiveness. So a national randomised clinical trial showed that people really liked it. It improved both mental and physical health, and actually it did save the NHS money. However, from a clinical standpoint, such as when considering the impact on reduction in cholesterol, it was not found to be better than regular care. So since then, limitations of Primrose have been addressed. So first of all, it was developed into something called Primrose A, or Primrose Adapted, which introduced a stronger focus on medication management, particularly conversations around statins, and more support for behaviour change and wellbeing with the addition of peer coaching. The latest iteration is called UCLP Primrose, and this integrates Primrose A with something called the UCL Partners Proactive Care Frameworks. So this approach expands care delivery by involving a broader range of staff, encouraging the joining up of care between primary, secondary and voluntary care, and prioritising patients most in need. So this is what the resulting pathway looks like. So I think Primrose like this looks quite complicated at first glance, but actually it's built around 5 really core elements. So first is finding out who should be supported first. So those with the biggest risk around their heart health, which is done via importing a tool into practice electronic patient records. This then creates outputs which informs the order which patients should be recalled for their annual physical health check. Secondly, we encourage people to provide a full physical health check, which also takes into account patient priorities and additional concerns. Thirdly, there's a clinical review with co-creation of a care plan. So this is patients and staff working together to develop a tailored plan based on health check results. This plan might include patients getting the right medication or being referred for additional support like peer coaching or behaviour change sessions. So the real heart of the original Primrose and Primrose A models. Fourth, really importantly, putting this plan into action. And fifth, last but not least, is supporting patients who are not engaging with their health check or resulting care plan, which could involve specialist support or home visits, for example. So to set up UCLP Primrose and put it into practice, there's a whole suite of free online resources, including manuals and training materials, and the training is now recommended by NHS England. However, as one of our participants said, actually making guidance clearer is not enough for implementation. More really needs to be done to understand actually the real world and overcome the challenges that people face to get evidence-based care up and running, which is very much what informed our current research project. So we wanted to look at evaluating the implementation of UCLP Primrose, getting it set up as part of normal care. So our research team had multiple collaborators, but was led by University College London and the Yorkshire and Humber Improvement Academy, and the Health Innovation Network UCL Partners played a role in supporting initial conversations around implementation. So in our research, we really wanted to understand whether UCLP Primrose could be set up and delivered within GP practices, with staff working collaboratively with secondary care and voluntary care, and identify what helped implementation and also the challenges faced by people on the ground. So to do this, from March 2022 to August 2024, we used a multi-methods approach. This included collecting data through interviews, meeting notes, and tracking uptake of the core elements of UCLP Primrose. We then used multiple complementary approaches to analysis, integrating these to inform our findings. So through our research, also really important to mention is we worked with 2 patient and public involvement groups, the first being Diamond's Voice and the second the Yorkshire and Humber Patient Safety Panel. So moving on to our key findings, we found that yes, actually UCLP Primrose could be implemented in practice. So it's adopted by 3 London boroughs and 1 primary care network up in Bradford, and there were 24 practices in total with their connected teams involved. So implementation for all of the sites was not straightforward, and the model was not set up in one go, and often implementation faced several setbacks along the way, such as low staff capacity or staff moving roles, for example. But by the end of the research, what we did found was that health checks and clinical reviews were delivered consistently, and so was signposting to additional support. So these were the elements that were relatively easy to fit in with existing ways of working, particularly the health check, which is already established for practices working towards their targets. The behaviour change sessions were delivered in most practices, with staff telling us actually these were seen as the really core bread and butter elements of UCLP Primrose. But then we turn to the non-engagement element, which involves kind of at its most extensive, the home visits. This was less up to the full extent and actually faced quite a few challenges. This included needing, for example, to recruit staff, finding transportable equipment, and also funding staff travel. And peer coaching, despite being a really core addition to Primrose A, was only actively used in 1 practice. And this was due to 2 core reasons, actually. So in 1 London borough and in Bradford, there was no existing use of availability of peer coaches. Then the 2 locations with existing peer coaches, implementation was stalled through issues with peer coaches being able to access patient records to be able to record their notes for working with patients with UCLP Primrose. So on top of that, we also did a bit of work looking at whether it was working how it should do. And bear in mind, this was not an effectiveness study, and we weren't restrictive about what should be recorded, like in a clinical trial, but there were indications of progress. So for some patients, this was labelled as small wins, but actually I think it's still incredibly important, such as patients being supported in a way that better met their needs, meaning that they did make it up to follow-up appointments, for example, all the way to patients actually being able to make really tangible changes, such as through medication change, their diets, or being supported to feel less isolated whilst working on their health with signposting to community-based walking groups, for example. This quote on the screen is actually from a population health nurse reflecting on one of the patients that she worked with. And then when we were able to pull some patient data, we did see some good examples of impact, such as 1 practice reduced their population who were non-engaging with the health check by 2/3. And then in another primary care network, they increased conversations around potential prescriptions of statins by 20%. So to summarise some of our overall findings and some of the key barriers and facilitators, integrated care transformation was challenging but possible with UCLP Primrose, and we did see some teams demonstrating progress to better joined up working. But we also found really systematic barriers persisted. So issues like data sharing and unconnected electronic patient records did continue to make implementation and efforts to reduce duplicated working really difficult. A few elements that were really associated with better chances of success included supportive and learning environments, prioritisation of upfront resources for planning and access to training, leadership and champion involvement, and ongoing reporting, reflection and problem solving. Local adaptation, whilst maintaining the active ingredients of the model, was also a really key finding. So I'm going to pause on this for a second just to give a few examples. So our implementation research helped us understand what could realistically be resourced, what was prioritised, and what fit into existing workflows. So we did observe some examples of best practice, particularly in progress to integrated care. So on the screen now, we actually saw lots of different examples of different staff across primary, secondary and voluntary care who took on different roles, and they're outlined in blue on the diagram. And then some of the examples of best practice are in green. Such as one of the London primary care networks, their teams actually started using existing multidisciplinary mental health team meetings to discuss patients needing that extra support as part of the non-engagement core element. So this started to move towards a no wrong door approach, meaning that patients who weren't engaging with primary care, who were maybe engaging with other services, could go on to be supported with their physical health in a way that better worked for them. And then finally, just to frame our overall implementation findings a bit more practically, we created an infographic kind of summarising the steps we saw, which was helpful for successful implementation of UCLP Primrose. So learning about UCLP Primrose, what UCLP Primrose is, its value and the evidence base behind it. Preparing the ground, so working to build some readiness and receptivity in the local system. Mapping current care, understanding existing processes, strengths and gaps. And also really crucial is identifying key leaders and potential implementation champions. Then we have adapting locally, so balancing the standardization with flexibility to fit local resource and workflows. And finally, building and enacting a plan, so developing an implementation strategy with room for iteration and problem solving, which is captured in revisit and revise. So I kind of now gone over and provided the big picture across London and Bradford. I'm going to now hand over to Gregor, who will share his insights specifically around implementation in Bradford.
Thanks, Pip. So I'll try and share screen. Now, can you all see that? Yep, okay, great stuff. I'll put it onto the slideshow as well. Right. Okay, so I'm Gregor Russell. I'm a consultant old age psychiatrist. And my main work's in memory clinics. So this isn't a natural home for me, but I am the R&D director for our trust, and through contacts with University of York, I ended up being drawn into the Primrose project. And what's this? A couple of years, 3 years on now, we're still doing it, which is a success story in itself. I think the project's had legs, but we're always learning, and I think this will come through in the slides I show that it's still a work in progress, and these things do take time. So, you know, Bradford Care Trust, it's the mental health provider for Bradford. We have a physical health team, so there's been a long-standing interest in the physical health of people with SMI in Bradford, and their services have been developed by people locally who've had an interest in this area, which Primrose was then introduced into that existing ecosystem. But that has meant it's quite a complex situation. There are some people who are open to the Care Trust would get their physical health checks from secondary care, and others would get them from primary care. And some people would get them from both, because the service didn't really talk to each other very well, despite the fact that both primary care and secondary care in Bradford are on System 1. And so in theory, should be able to know what's happening. In practice, for lots of reasons, that doesn't actually work. So we've got a situation where there's duplication, where sometimes things are being missed, and unclear ownership and lines of accountability. So that was one part of it. Another part is that, and which should count towards us being able to make a success of this, is that this is an area of interest for Bradford, and that there is a transformation programme looking at this very area of how we improve physical health in people with severe mental illness. So there's structures set up already on an integrated care system level, which Primrose should have been able to take advantage of. And I think we did manage to get ourselves known to the transformation programme and adopted, which should have given some impetus behind what we were doing. But you know, I'll come back to that and wonder just how effective that's been and how effective transformation programs actually are. Nevertheless, we got going, and from April 2023, UCLP Primrose was introduced in one of the primary care networks and became treatment as usual for that primary care network and for anyone from that PCN who was having their health checks in secondary care with us. That network was chosen because the clinical director was also had the local health and care partnership role for mental health and physical health, so that she had a special interest in this area and was happy to volunteer her and her colleagues for taking this on. So again, favourable ground to be working in. We had an ally within this primary care who could help push this through. A lot of people are needed. So, as I say, the primary care network, the care trust, and the people working in the physical health teams there. We have had support and input from Mind and Bradford District in Craven. They are now. They've extended. They were involved in developing the training and delivering that to the staff who were going to be doing Primrose. The Integrated Care Board was actually, I think it was the place part of the Integrated Care Board and the Health and Care Partnership were behind us. The research arm of it was being delivered by the Improvement Academy, who are an NIHR team sited in Bradford, and the University of York with colleagues there who were supportive as well. So what went well? Well, a lot of enthusiasm from staff. When we took this to the staff who were going to be doing it, they all thought this was a good thing to do, and they were keen to know more and how they could help. So that was great. There was goodwill that we could work with there, and I think the training went very well. There was a bit of trick, it was a big ask. Release people from their day job and ask them to go to a different part of the city to sit in a room and hear about Primrose for half a day on, I think it's 2 occasions, or did they do it? We ran it twice. It was maybe a different staff each time. Nevertheless, there was such good support from the primary care network. We did get people coming, and I think having people there in person really made a difference. It meant you could do a much kind of richer form of training delivery and keep people better engaged than trying to do it through the computer. And I think that served the project well. We also were able to identify people to do the intensive behaviour change bit of the project. I was worried we might struggle to find enough people to be able to deliver this. In fact, that's not how it worked out, but we did get people identified and trained. And it was widespread collaboration here. The different bits of the NHS and also the voluntary care sector needed. So we did get it up and running, and throughout 2023 and 24, I think that's when it was probably at its strongest in the primary care network. And we've pulled some data, and we've shown there was an impact. There was a detectable signal here, particularly statin prescribing, which was one of the primary things we hope Primrose will do. We managed to show a 20% increase in the number of people in this population who were getting statins by the end of that period. So that was encouraging to see that even, and we'll come to the shortcomings of it, and it wasn't implemented as fully as we'd like, but even with the partial implementation, we could see a difference. But there were some snags. So one of the big snags was about outreach working. Pip mentioned this earlier. We had funding approved for this, but just having something funded doesn't mean to say you've got someone doing it. It then ran into the sorts of things that people working in the NHS will be familiar with. There was a delay getting the funding released, and then posts had to be drawn up, and then the HR had to approve them, and they weren't happy, and it had to go through various cycles of that. And then finally we had a chance to appoint people, but the thing is, they were then by this stage secondments, and their line managers wouldn't release them to do the secondments, and this was already kind of well through the year. So in fact, we couldn't get anyone into the posts, even though they existed. And we ended up with a bit of a kind of last minute backup plan of pulling someone from the physical health team to go and do some of these outreach checks, just to show what the potential would be. And I think we did show that if we had someone in that post, it would have made a difference, and we would have got far more people pulled back into the Primrose system. As it was, we didn't show an increase in the number of annual physical health checks done, but that's, I think, because the thing that would have done that, we didn't get till too late in the year. Communication issues, systems talking to one another. Even if you're on the same computer system, it doesn't mean that you don't have problems. We couldn't task GPs to let them know that we had seen people in secondary care and asked them to follow up with a clinical health check to do prescribing, and primary care couldn't be sure we had done the health check, and they could get penalised by QOF as a result, so they often ended up doing them again. So even one of the things we sold this on, we were stymied by the IT infrastructure. And the kind of understanding of Primrose varied within the PCN. There's 4 practices. And the clinical director was one of them. They were the ones that were clearly head and shoulders above the rest. that half of the new statin prescribing happened at that single surgery. And I think that showed the importance of having someone on the ground who actually had ownership of it. I thought it would be enough that the PCN would, and the PCN manager was signed up. But I think you needed someone actually in the building able to advocate for it, which we didn't necessarily have at all sites. And the stratification tool you've heard about, the steer from Bradford from the GPs was they felt it was burdensome, they felt it was unnecessary, and they didn't just not add anything. They had systems for making sure people got recalled, and it actually worked against this, and they ended up having to double bookkeep. They were doing two systems to be able to do the task. So we've not been able to persuade them to stick with that bit of it. But we're still going. There's been a kind of slow, I think, slipping of things over the course of the last year, I'm afraid, and we're looking at how we address that. The informatics issues need solving. We've yet to work out how to sustain the training and bring new sites on board. And we didn't have as much uptake of the behaviour change as we thought. And I think we think that's something to do with the conversations that were taking place and the clarity of whose job was it to suggest this and refer. So we had a meeting of the Health and Care Partnership stakeholders a couple of months ago. We were wondering about further rollout, and we were pushed back on that. There was a feeling that we had to really get it working properly at BD4+, the current PCN first, and show its potential before we could take it elsewhere. But then discussions of how we would do that. So how can we get how can we re-energize it? How can we take it beyond where it got to? And I think we need someone at each of the sites, and I'm in discussions with the chair of the transformation panel to try and get some of that funding and release a person to actually be present a day a week at each of the 4 practices to be the on-site face of Primrose and be looking at what people are doing and reminding them about what's involved, and see if we can get the sort of engagement we had at the best practice widespread across all 4 practices. And I think if we can do that, and we can show the really quite large uptake of statins that we did at the best practice more widely, then we might be able to take this beyond just simply that PCN and have it adopted more broadly. I'm not sure if I've gone over my time, or I'll draw it to a close there anyway.
Perfect. Thanks, Gregor. And moving straight on to our final site, and then we'll come together for questions at the end. Over to you.
Hello, just bear with me a second just while I share my screen. There we go. Can everybody see that okay? Yeah, is that right? Yeah. Cool. Fantastic. Okay, so kind of following on from what UCLP Primrose did, sort of in other parts of the UK, what we wanted to do on the whole SMI project was build on that work, but also address some of the issues that the North East face that are not as prevalent elsewhere in the UK. So the North East and North Cumbria has its own sort of geographical considerations when looking at healthcare, and there's worsening health inequalities, particularly for people with severe mental ill health. And what we wanted to do was look at that model and that service model of UCLP Primrose, and look at how we could adapt that and implement either the model or components of the model to fit the needs of the North East and North Cumbria. And the way we did that was to kind of separate it into 2 phases. So that first phase was really about mapping the currently delivery landscape of physical and mental health services for people with severe mental ill health, and look at what sort of resources and assets we have, and the challenges of providing more holistic ways of service delivery, and also then to identify opportunities for service enhancement that could then sort of theoretically be sort of plugged by adapted components of the UCLP Primrose model. And then moving on to the second phase of that then, we really wanted to map both the pre-implementation and the implementation landscape and processes for service enhancement and implementation. And we did that in kind of two ways. We did sort of a real-time mapping of something, of trialing something new, but we also retrospectively did that for existing services to really capture the learning around how services are developed, adapted, implemented and enhanced over time. And also to consider how we might reallocate existing provision and resources to better serve those that might need them. So we looked at sort of a lot of external and internal factors to do with implementation. And when we talk about internal or the inner setting, what we're referring to is sort of the local organisations that are looking to implement something, and the internal attributes that are impacting or not impacting that implementation process. So in our case, the inner setting will refer to the Mental Health Charity Trust in the North East called CNTW, or primary or secondary healthcare settings and organisations. And then for the outer setting or the external, we're referring to things that are happening and impacting external to an organisation. So that could be things like something that's happening politically or at a national policy level, wider geographic impacts, factors within the community, or also what's going on in sort of voluntary community and social enterprise organisations. So with similar to Primrose, we had a lot of sources of information and data that we used to sort of finalise our findings and recommendations. And I know there's a couple of people on this meeting today, so I just wanted to give a little shout out and a nod to our sort of dedicated community advisory group that have really helped shape this project from the beginning and every step of the way since, especially around how we've interpreted our findings and framed them in the best way possible. So in terms of sort of data, we did ethnographic site visits, we scrutinised policy documents, but we really sort of had a good chat and a really good sort of data collection with our experts with lived experience. So these are people in our communities that have experience of severe mental ill health and trying to access or unsuccessfully access services in the North East as well. We also spoke to healthcare professionals as well, so commissioners, delivery staff, GPs, policymakers, lots of different people, and we did one-on-one interviews, we did focus groups, and we also did something called future workshops, which is a democratic participatory approach that identifies problems but then also explores some solutions as well. And then we did some more in-depth ripple effects mapping workshops to look at the implementation processes and experiences of current established services and service models. And one of the things we tried to do throughout the, I don't seem to be able to change my, there we go. So one of the things we tried to do throughout this project was to really make sure that we were advocating and amplifying the voices of the people and the communities that we're trying to help. So what you can see from this illustration is a really good example of one of our future workshops that really sort of captures and highlights the challenges that service users may face when trying to access our services, but also some of the ideal solutions and aspirations that they might have for living well, living longer, and thriving in the community. And these slides will be distributed after this, so you'll be able to look at this in a lot more detail. And I recommend it because it's a really nice illustration as well. And then sort of expanding on this sort of need for holistic approaches and holistic health promotion, what does that actually mean? And more importantly, what does it mean to the people that are using these services? So we have some great quotes here from our participants that really advocate for service delivery that's individualized and personalized and responsive to individual needs and differences. Care support packages that are proactive and preventative as well, rather than reactive. Services that are accessible, easy to navigate, and are also sensitive to different and ever-changing challenges that people might face with engaging. And then just on this, one of the things we did with our community advisory group was quite recently was to look at our data and findings and ask them to pick out some of the most important aspects and sort of the headlines really of what we've been doing. And I just wanted to share this as some of the headlines of what they suggested. So some of the themes that really resonated with our advisory group was to break the stigma and labelling around mental ill health diagnoses, spend more time with service users to address not only what matters to them, but what also works for them as well, and then preventative support that helps people to stay well as opposed to only being available during crises. So while there's this strong advocacy for change and for more preventative, for more holistic approaches, we do realise that it's easier said than done, and that our healthcare systems at the moment are quite challenging in the way that they are delivered and the way that we adapt and implement things. So Ilaria is going to talk to you now a little bit about some of the solutions and the things and ideas that we think might be achievable and sustainable for healthcare systems.
Thank you. So as Dan mentioned and really well explained, we've been chatting with a lot of people from the community as well as people working also in services. And thanks to this both phases of the project that we've been involved and working on, we managed to sort of develop recommendations or suggestions that are mainly targeting two kind of groups. So I'm presenting now the suggestions and recommendations that are more targeted to the strategic and policy level, and what kind of action there should take place to actually help people living better and thriving in the community. The first one is obviously the presence of a clear leadership, which, as you can imagine, we found that is quite missing at the moment. And especially, we found really positive examples of mid-level leaders really championing and leading innovation and services, promoting as well as the innovation, also new services and creative approaches to healthcare and health promotion as well with people living with severe mental ill health. But also, what is really, really important on the top of the leadership is also partnership and the idea of cross-boundary work. So not being really the silos that we've been facing so far, with, for example, primary care only focusing on primary and secondary be really separated. But then the ability that people can have in working across these boundaries and being more flexible as well. The referral pathways plays an important role as well, with potentially considering a more kind of step up, step down support approach, with the consideration of co-occurring wider needs. So the idea of having a more kind of holistic approach to healthcare, but also potentially having self-referrals, community referrals, follow-ups after the annual health check, and re-engagement opportunities to allow people to go in and out based on their needs. Also, a language shift, not only when we talk with people with lived experience of severe mental health, but also from a more clinical and medical establishment. So we should try to move away from a really kind of medicalized language. So, for example, during our research, we found that the idea of talking about referrals is not ideal, but people prefer to call them conversation, or the idea of saying, well, we will pilot, for example, this service. We found that a lot of, different people prefer to say prototyping instead of piloting, because it suggests an idea that the funding is going to run over and then the service might end. And lastly, on this slide, what is important to consider is also targeting people that are not on SMI registers at the moment, because we know that the register omit people that are not, for example, engaging with healthcare system, because they are maybe not registered with a GP, or they do not have a specific diagnosis of SMI, or their diagnosis might have changed over time. So we need to be mindful who we are missing. Next slide then, please. Thank you. So other kind of recommendation and suggestion that we really want to show from our research, always at the strategic and policy level, is the idea of moving beyond reactive models, trying to be more kind of proactive intervention where, again, there's flexible engagement, the idea of building trust and relationship will then facilitate access and the consideration of wider needs. At the policy level, they need to make sure that implementation of national policies are also happening at a local level to avoid the issue of the postcode lottery. There needs to be more consistent across regions, across areas on what is the offer for people living in that specific area, but also more stable and long-term funding to either commissioning but also service delivery staff. We really need consistency again in terms of workforce, as well as the opportunity to maintain and develop long-term relationship with service user, with staff, but also with partners like community and voluntary organizations. And last but not least, obviously, the technology and data sharing. Participants reported that this is a massive issue across communication. So as much as we talk about integrated care, there are different systems which sometimes, well, most of the time limits communication, but also information. And then the person, the service user, need to go through and repeat their story again and again, which is not ideal. Next slide, please, again. From a more kind of service delivery and also public member recommendation or suggestion that we make is we definitely need community-based models and peer support approaches so that people can develop and can thrive within the community instead of being in a different place to where they are. Also here, a language shift. So similar to the previous recommendation and to the different kind of audience, we really need to be mindful. And also, I don't know if you noticed, but we are adopting, for example, the term severe mental ill health instead of SMI or severe mental illness, because that's something that has been driven by our community advisory group. We need to focus on holistic health support. So we really need to consider the wider picture of a person and not only physical or mental health, but the person as a whole. And a suggestion more for the service delivery staff, creating spaces for sharing best practices, and also the best practices, but also good ideas and good services that are running, for example, in an area. If there would be a space where people can meet and share in an informal way their activities, good ideas can spread and benefit more people. And lastly, again, embedding co-production principles. So people, service user, and people with lived experience need to be really active actors and actively involved in shaping and refining services. So that we say are our recommendation, but we are obviously open to also listen from you, your potential ideas and suggestions. So thank you so much.
Lovely, thanks all. Just conscious of time, I'll just, I think, stick to one question and ask you just to keep to a minute each for some final reflections before we open it up. Some commonalities, I think, in the lessons that came across from the pieces of work in different locations. And I should point out that the different research teams have met regularly throughout, and I think it's provided quite a lovely peer supportive network in and of itself as we try and navigate some of the challenges of doing implementation research. Pippa, I thought your emphasis on the need for local adaptation was really interesting, and also perhaps creates us an opportunity for us to test the efficacy of different models in practice. The phrase about small wins, but really meaningful and hugely important personal changes, I think, is important to remember. And thinking about the role of Primrose as a trigger for perhaps wider engagement, not just in the physical health pathway, but with health services more generally. Gregor, I thought it was your reflection on how things were adopted enthusiastically by the transformation program, but what that actually meant in practice and the tensions of that was interesting, and it is perhaps something I can see you perhaps wanting to comment on that.
I mean, I suppose, yes, it's kind of, it should have been a fertile landscape. Even our ICB, one of our 10 big ambitions as an ICB is to do exactly this, to kind of narrow the the gap between the kind of health outcomes experienced by people with severe mental ill health and the general population. So kind of all the system drivers seem to be aligned, but when it comes to actually then doing something, I mean, I think funding was made available. So I'll say that kind of, and in this day and age, that's not a given. So there was genuine financial support provided, but not an awful lot of structure support. How would I, as a kind of an inexperienced project manager, kind of have a team behind me to help push this through and show me what to do? Well, the answer is I look at my colleagues on the physical health transformation steering group, and they're all just people like me, kind of with busy day jobs, and kind of no one's got that kind of, there's not a team out there in the NHS to help implement these new things. And I think that's difficult, because then you're down to the skills or otherwise of enthusiasm of people that are trying to do stuff. So yes, there's limitations there.
And that speaks really nicely to my question, which I'll throw across to the others now, which is, if there was to be one big change that you felt from your experience during the course of this project that could really drive or accelerate implementation, what would it be? So perhaps a kind of clearly established support network and high-level specific leadership for this would be Gregor's suggestion. Pippa, over to you.
I think one big change is a challenge. I think there's lots of different changes that need to happen in tandem. But if I was to really try and boil it down, I think it might have been Carolyn that put in the chat. We're still going back to the Leicester Tools tagline of "Don't just screen, intervene." And I think at scale, if we're looking at what needs to happen, there needs to be a lot more shift in terms of culture change to realizing that the screening part is really, really important, but actually the prevention and intervention is also key. So I think something we've been talking about is potentially more shifting towards generalist work. So it's more the norm that staff are being trained in physical and mental health, and hopefully social health as well. And that we do actually know what good care looks like and are able to embed it in a way that patients are getting really what they need, and it is holistic, as Dan and Ilaria have been emphasising as well.
Brilliant. Dan, Ilaria, over to you.
Well, the big change that I would love to see, I would say, is two things mainly. Well, I know it's one, but stability in terms of allowing people to, and consistency. So allowing people working in these services to be not so worried about the potential issues of a different job title or changing roles, as well as, for example, allowing service users to see the same person over and over again. I think these kind of things will help to build trust in the system, because sometimes it's something that is missing from a service user perspective, and also might be less of a burden on who is working or actually delivering the service.
Dan, did you want to add anything?
Yeah, just kind of from my experience, a little bit of a different take that I think would really help is just allowing time to sort of develop those collaborative relationships between researchers and sort of people in our healthcare systems. I mean, it's commonly said in a lot of implementation things is that people underestimate the time it takes to build these collaborative working relationships, and they're right. I definitely feel like I personally underestimated how long it would take to really establish and build that trust, rapport with our collaborators within health services and things, but also them being able to have the opportunity to engage with us as well, to make something that is a good working relationship to better services, but also something that can be sustained long after we've stepped away as researchers as well.
Brilliant, thank you. So maybe I'll throw that question open to the floor. Feel free to sort of use either electronic hands or physical hands if I can see them. Does anyone want to offer any comments on anything that's been shared, or where they think perhaps work or change is needed? Just scanning through. Sorry, just following the chat as well. Some interesting things being put up there. Nusrat, feel free to unmute and chip in.
Hi, hello. I'm sorry I was a bit late, but did get part of it. Um, Caroline kindly shared the link. What I wanted to ask is most of my work is around ethnic minorities, and some of those ethnic minorities are at high risk of severe mental illness. I was wondering if you were able to engage with this group, British South Asians, British African Caribbean community.
I'll throw that over to our research teams who can speak about the profile of participants that they worked with at each of the sites.
Bradford is a very diverse city. We don't have, it wasn't a study which was looking at quantitative outcomes. So we don't have specific data on the ethnicity of people that had the health checks. And it's certainly possible there could be, I think there's about 70% of people had a health check. It's possible that people from minority ethnic communities were underrepresented in that. We do have the big news is that the Mind and Bradford and Craven have got a parallel project now with health engagement officers that we're working in all primary care networks across the city, so including ours in the Primrose project, and they will then do the outreach part of the model, which we were struggling to fill. And they're happy to, we're not stealing them or anything. They're happy to do it. It's kind of what they'd be doing anyway. So they're happy to say that that's part of Primrose delivery. So if we do have underrepresentation of people from minority ethnic backgrounds, this should address it, that we will have, someone who's from a South Asian community will be going out to be finding people and bringing them back in.
Thank you.
Dan, did you want to come in on that?
Yeah, just to sort of say that that's right. You have highlighted a very sort of important point that I know from the whole SMI project. It's something we have acknowledged and something that is a real issue in terms of sort of mental ill health research. Is that there is an underrepresentation from certain groups of people that are more at risk of having severe mental ill health, and that can be ethnic minorities, it can be religious communities, it can be the LGBTQIA communities as well, and also as me and Em have been discussing more recently, we have a lack of representation in our research from people that are in inpatient care as well. So it is something that is on our radar, absolutely. And as we sort of come to the end of our whole SMI project, we are looking at ways that we can continue our research and focus a bit more on the people that we're not seeing. And it's one of our sort of recommendations is to start thinking about the people that do engage with our services. That's all great, but it's also the people that aren't engaging with our services that we need to be considering more and looking at ways that we can engage. I like one of the things that we've one of the bits of data we've had from one of our commissioners is that they really don't like the term hard to engage, because it's not them that's hard to engage, it's us that's doing it wrong. So I really like that, and I think that's something that I think about quite often.
Thank you.
That's a really nice, I think, general point for us to finish on, in that today's seminar is the culmination of 3, 4, 5, 10 years of work and really trying to grapple with how we support physical health better for people living with SMI. And you can see from the experiences that people like Abby have shared in the chat, we're still not getting this right consistently. And there's that balance between having conversations about all the different components of people's lives, whether that's related to the management of their mental health or not, that we might want to consider in those health promotion conversations. So I think Caroline has shared a wider trial that's going on. The people who've presented in this call are continuing to do work on this area. So if you are interested in collaborating, getting involved as a public member, helping us to do more research in this area and to do it better, please do reach out to us. We'd be delighted to hear from you. I'll pass over to Claire now, who may just want to finish up by signposting towards other sessions in this series.
Well, thank you so much, all of you. I'm sure everybody will agree it's been a fantastic and very interactive seminar. There are more lined up in our seminar series. If anybody would like further details, please do not hesitate to contact me. You should have my email address from an email I sent to you all yesterday. So any questions at all regarding the programme, please feel free to get in touch. We will put the recording of this webinar on our website, so you should be able to see that in the next few days. So thank you all once again.
Thank you.